Hi everyone, and in this video I'll be discussing the drugs for dyslipidemia. Now, what basically we understand by the term dyslipidemia, it is nothing but a lipid abnormality. Now, what is the problem if lipid is abnormal? The cholesterol abnormality, what will happen? The problem is it will form a atheromatous plaque. Now, when it forms a atheromatous plaque in the artery, it can rupture and it can embolize to other parts. So, patient may have stroke, AMI, patient may end up with peripheral arterial occlusion as well as even erectile dysfunctions can happen with this. So, main problem is the MI. So, the risk of MI increases if the patient has dyslipidemia. So, why this topic is most important? Because we see the younger people dying with heart attack, and that's the reason statins are the main drugs what are to be used in the management of dyslipidemia. So let us understand what are the drugs which we are going to use it in dyslipidemia. So dyslipidemia, the problem is whenever the lipid is abnormal, suppose this is the artery, so there is a chance that there is a formation of a plaque, and this plaque what is formed, we call it as the atheromatous plaque. So it is called atheromatous plaque. And if it is occurring in coronary arteries, it is also called as atherosclerotic cardiovascular disease, and that will lead to the angina and myocardial infarction. Now, sometimes these plaque may rupture, and that can lead to the formation of emboli, and they can lead to MI. It can lead to stroke. It can lead to peripheral arterial occlusions, peripheral arterial occlusion. Even the small arteries in the penis can get blocked, and that can lead to erectile dysfunction. So the basic thing what we need to do in dyslipidemia is to manage this dyslipidemia. So what is the aim of therapy? The aim of therapy is simplified to decrease the total cholesterol and to decrease LDL, to decrease VLDL, and to decrease the triglycerides. So the drugs for dyslipidemia are going to do this, and they will increase the good cholesterol, that is SDL. So the major aim of all these drugs is to do this job. So all the drugs what we are going to discuss, they will do this. They will decrease total cholesterol, they decrease LDL, VLDL, triglycerides, and they increase SDL. So let us understand what the drugs we need to understand in this topic. Number one, we have a drug called HMG CoA reductase inhibitors. So these drugs are called as HMG CoA reductase inhibitors. Now the example of drugs, examples are rosuvastatin. Now read the name, it ends with vastatin, and most of us remember it as statin because the confusion always arises because there is a drug called cilastatin. So cilastatin is combined with imipenem. So to make the imipenem longer acting, that comes in different topic. Pentostatin is an anti-cancer drug that also ends with statin. So to avoid the confusion, please remember the statins as vastatins. So rosuvastatin among all the statin is the longest acting. So that is the specialty of this. And then we have a statin called atorvastatin. The specialty of atorvastatin is this is safe in a patient with renal dysfunction. It is safe in a patient with renal dysfunction. That means in the exam they can ask you which statin is safe in renal failure without any dose reduction. We can give is you can give it without dose reduction in renal failure. Without dose reduction in a renal dysfunction patient, that is the advantage of atorvastatin. So till now they have not asked this question. In the future this may come. Which statin can be given without dose reduction in renal failure? It is atorvastatin. Now moving on to the other statin, the other statins are simvastatin, and one more is called lovastatin. Now, most of the statins are active ones, but these two are prodrugs. That means they become active, then only they will work. The other statins are pitavastatin. So pitavastatin, the specialty is it is the most potent statin. Now, correlate this with general pharma. What do you mean by most potent? It's simple meaning that you are using it at low dose. That's it. So pitavastatin, we use it at low dose. And we have another statin called pravastatin. And then we have a drug called fluvastatin. So these are the statins which are called as HMG-CoA reductase inhibitor. Please remember them as vastatin. So this is the importance what I need to tell you about these drugs. Once we know about a drug, what is the mechanism of action? How do they bring down the cholesterol? That is LDL. So you know that in cholesterol biosynthesis, we have HMG-CoA. From HMG-CoA, we get mevalonate. And the mevalonate is going to give rise to cholesterol biosynthesis. Now the enzyme which is rate limiting, it is called HMG-CoA reductase. So these drugs, that is called as statins, they are going to inhibit the HMG-CoA reductase. So this is their mechanism of action. Now what happens when you inhibit this enzyme? The next step what happens is there is decrease in cholesterol in liver. So liver synthesis of cholesterol decreases. So what happens? The liver requires cholesterol for synthesizing the hormone. So it will increase the LDL receptor in the liver. It will increase the LDL receptor, and the LDL is taken from periphery. So it is taken from periphery and given to the liver. And there is decrease in LDL. So this is the major mechanism of action of statins. So they inhibit HMG-CoA reductase. What happens when you inhibit that? The cholesterol synthesis doesn't occur in the liver. So liver requires cholesterol. From where does it get? It will take it from the periphery. How does it take it? Increase the LDL receptor on the surface of liver. So LDL is taken from periphery and given to the liver. So the LDL levels decreases. Not only they decrease LDL, they are also known to decrease the other parameters like the total cholesterol. They decrease the VLDL, and they also decrease the triglycerides. Now they are also shown to increase the levels of HDL. So these are the minor effect. The major effect is to decrease LDL. Now apart from that, these statins are also shown to produce pleiotropic effects. So there is something called pleiotropic effect of statins. Now what do you mean by pleiotropic? Multiple effect. Apart from this, they also have multiple effect. That is, they will cause atheromatous plaque stabilization. Atheromatous plaque stabilization. Now why should we stabilize the atheromatous plaque? Because if you don't stabilize it, the plaque will progress. It will obstruct the coronary artery. Patient may die with MI. And also it has shown to decrease the plaque rupture. So when the plaque will not rupture, there is no chance of emboli. That complication will not happen. It also has anti-inflammatory property. It has anti-inflammatory property, and also it increases nitric oxide in endothelium, which is good in case of atherosclerotic cardiovascular disease. And also it has shown to have antioxidant property, and it has shown to decrease the platelet aggregation. It has shown to decrease platelet aggregation. So that is what we mean by the pleiotropic effect of statin. Basically, you remember the mechanism of action is they inhibit HMG-CoA reductase. That's the basic thing you need to remember. Apart from that, additional advantages, they have the stabilization of plaque, and we don't want a plaque to rupture. We don't want a plaque to progress. This is the advantage what we see with them. So until now, we understood the drugs, we understood the mechanism of action. Let us understand the pharmacokinetics. Now these statins are metabolized by the enzyme cytochrome, that is 3A 4 bar 5. So they are metabolized by this. So if a drug is metabolized by this enzyme, the problem is when you add statins with an enzyme inhibitor. So if you add statin with enzyme inhibitor, for example, erythromycin, ciprofloxacin, what happens? This combination will lead to increase in statins level. Now, more the statin levels, there is more the risk of myopathy. So the risk of myopathy increases as the statin level increases. So the drug interactions are very, very much. So don't combine with enzyme inhibitors and statins together. Now there are statins like pravastatin, fluvastatin, and rosuvastatin. Now these statins, they don't depend on the metabolism of the drug with the help of cytochrome. So the metabolism of pravastatin, fluvastatin, rosuvastatin don't depend on the metabolism by cytochrome enzyme. That's why they have less drug interaction. So these drugs have shown to produce less drug interaction. That is one more advantage. Now moving on to another important aspect, statins absorption is increased with food. So their absorption is increased with food. This is another important point. Now, most of the patient will ask us, sir, when to administer statins? Most of the statins are given at night time. Statins are given at bedtime or night time. Why it is given in the night time? The reason is the enzyme, what we call it as HMG-CoA reductase. The enzyme HMG-CoA reductase is active in the midnight, that is between 12 a.m. to 2 a.m. So that's the reason we want the drug to effectively work in the midnight. So better to give them and stop the enzyme activity in the night time. But there are two statins, rosuvastatin and atorvastatin. These statins are longer acting. So they need not be given at bedtime. They can be given at any time of the day. Any time of the day, because they are longer acting drugs. So any time of the drug you can give them. So that is about pharmacokinetics. Moving on to the adverse effect of statins. Adverse effect of the statin can be remembered by the mnemonic HMG itself. So you can remember by the HMG. First I will explain what is H for. H for these drugs can produce headache, and one more H, they can cause hepatotoxicity. So how will you know it has caused hepatotoxicity? Will the patient come and tell us no? So when we do the liver function test, when you do that, the liver enzymes are increased. So there is increase in liver enzymes during LFT. Increase in liver enzymes when you do LFT. Right? So that is what we see as hepatotoxicity. Next, it can increase the glucose, high glucose. H for high glucose. So it can increase the risk of diabetes. It can increase the development of diabetes type 2. So you can ask a question, when it increases the diabetes, then why are we giving statin? When we know the drug causes diabetes, why are we using it? Now remember, when I tell adverse effect, not everybody will get that adverse effect. Second thing is, now imagine the patient develops diabetes, but he is dying of MI. So what is the risk and what is the benefit? The benefit is patient survival. So he will survive from the MI or a heart attack. But there is a risk of diabetes. We have to take a risk, and without giving prophylaxis, you are putting the patient for MI risk. So that's the reason even the risk of diabetes increased, we are using statins as prophylaxis. Then YUM. So YUM stands for myopathy. So the drugs produce myopathy and patient will complain of muscle pain. Now I explained to you statins. If the statin levels are high, the risk of myopathy increases. Now when the statin levels will be high, when you are combining with enzyme inhibitor, that is the reason sometimes statins high level can lead to myopathy. Now this myopathy can lead to rhabdomyolysis, that is lysis of muscle, and the myoglobinuria. So myoglobinuria, and patient may end up with renal failure. So this is risk. Even this adverse effect is 1%. There is a risk. So when you use statins, you should be very careful when you combine with enzyme inhibitors. So higher the statin levels, more is the risk of rhabdomyolysis. In practice also, if the patient develops myopathy, we try to lower the dose of statins so the patient can tolerate it better. Next, remember M for mother. M for mother, statins are contraindicated. Statins are contraindicated in these population. Don't give it in pregnant. It is not used in pregnant. Can you use it in lactating women? No. It is contraindicated. Can we use it in children? No. It is also contraindicated in children. But is there any statin approved in children? I'll just give a note of statins approved in children. Now remember, in a child more than 8 years, the statin that is approved is the pravastatin. So a child more than or equal to 8 years, or a child more than or equal to 11 years, the statins approved are the atorvastatin, lovastatin, and simvastatin. These are approved. Now these statins, why do you use it in a child? Because they will have familial hyperlipidemia cases. There we use them. Clear? So now, until now I have told you the adverse effect: H for hepatotoxicity, headache, high glucose, M for myopathy. Don't combine with enzyme inhibitors, and one more M for mother, contraindicated in pregnant, lactating, and children. So for children, only few drugs are approved, that too above 8 years, and I given the list here. The last letter G for the GAT upset, your favorite, nausea, vomiting, diarrhea, that can be caused by statins. Now coming to the use of statins, where do you use statins? Number one, in familial hyperlipidemia conditions. Familial hyperlipidemia conditions. Number two, we use it as prophylaxis. Prophylaxis in patients with MI and a stroke. And a patient has diabetes with dyslipidemia. So he has both diabetes and dyslipidemia. Then statins are the drug of choice to manage dyslipidemia. Statins are the drug of choice. Now, there is a concept called high intensity statins. High intensity statins. High intensity statins. What do you mean by that? Now, high intensity statins are shown to decrease the LDL. They can decrease the LDL more than 50%. So they can reduce the LDL more than 50%. That is called high intensity statins. There are only two high intensity statins, and the drugs are atorvastatin. So the dose of atorvastatin is around 40 to 80 milligram, and one more drug is rosuvastatin, and that is used at the dose of 20 to 40 milligram, and that is what we mean by high intensity statins. And remember why it is called, because they can reduce LDL more than 50%. So these high intensity statins are preferred in high risk individuals. Then moving on to the next, it is also used in metabolic syndrome. So metabolic syndrome also has dyslipidemia. There we use it. So these are the uses of statin. Remember, high intensity statins, that means they reduce the LDL more than 50%. Only two drugs. What about other statins? They are moderate statins intensity. That means they don't reduce cholesterol, LDL that level. So they will reduce the LDL up to 30 to 50%. That's it. Now, nowadays the target LDL, what you should achieve, is less than 70 milligram per deciliter. So this is the target level as per the recent guidelines. You have to reduce the LDL less than 70 milligram per deciliter to achieve the targets. Right? So that is about statins, that is HMG CoA reductase inhibitors. Moving on to the next target, they are called as fibrates. They are called as fibrates. Let me write the drug name. They are fenofibrate. You see the name ends with fibrate. Then we have benzafibrate. Can you see here? Their name end with fibrate. Then the clofibrate. And one more, it is called as gemfibrosyl. The only difference is gemfibrosyl doesn't end with that, but it has fiber in the name. So these are fibrates. Now, when we know the fibrate, what is the mechanism of action? Let us understand. How do they work? Now, fibrates, they are known to stimulate a nuclear receptor. What is the nuclear receptor name? It is called as PPR alpha. So it's a nuclear receptor. The full form is peroxisome proliferator activator receptor. So it's a nuclear receptor. It will lead to synthesis of lipoprotein lipase. So it will increase the synthesis of lipoprotein lipase. And what does it do? Lipoprotein lipase will cut. So it will cut VLDL and releases triglycerides. So it will release triglycerides from VLDL, and when the triglycerides are released, these triglycerides are metabolized to free fatty acid, and then they are converted into energy. So this process of conversion of triglycerides into free fatty acid into energy is also mediated by fibrates. So there are two important actions. One is by stimulating PPR alpha and also converting triglycerides into free fatty acid and then to energy. So by doing that, these drugs decreases triglycerides. So maximum triglycerides are decreased by fibrates. Please keep that in your mind. Which drugs decrease maximum triglyceride is fibrate. Do they only decrease triglycerides? They will also decrease the total cholesterol. They decrease LDL. They decrease VLDL. And they increase HDL. But the maximum reduction in triglycerides is seen with fibrates. Now, whenever I talk about PPR, I just want to correlate with other topics. Remember, there is something called PPR gamma. Now, can you guess which drug is a PPR gamma agonist? Now, a diabetic drug, pioglitazone, we use it in diabetes. So it acts through PPR gamma. Don't confuse alpha and gamma. So gamma for pioglitazone. And there is a drug which can act on PPR alpha as well as gamma, and the name is called saroglitazar. Now this is a drug discovered in India, and that is approved for managing diabetes as well as dyslipidemia. So patient with diabetes and dyslipidemia, the drug that is preferred is saroglitazar. It's a new drug which can take care of both because it's a stimulator of alpha and gamma. So we know fibrate, we know the mechanism of action. What is the use? The use is any familial conditions leading to high triglyceride levels, familial hypertriglyceridemia, or any condition where the triglycerides are more, because it has severe hypertriglyceridemia. For example, if it is more than 500 milligram per deciliter. Usually, if the triglycerides are less than 500, statins will take care. We add fibrates only if it is more than 500 milligram per deciliter. Moving on to the adverse effect of fibrates. Fibrates' main problem is they can cause myopathy. And second important problem what they cause is they increase the risk of gallstone. So gallstone risk is increased. The reason is they increase the lithogenicity of bile. So they increase the lithogenicity of bile. So they can increase the risk of gallstone, and maximum risk is seen with a drug called clofibrate. Clofibrate, you see maximum risk. So they can ask you which group of anti-dyslipidemia drug can cause gallstone. The fibrate, all the fibrate can cause, and the maximum is seen with clofibrate. Now the drug interaction is, can we combine statins and fibrate together? Take a guess, can we combine statins and fibrates together? what happens? Both of them cause myopathy. The risk of myopathy increases. There is increase in myopathy risk. So if you want to give a fibrate, which fibrate is better to combine with statin? The fibrate better to combine with statins is fenofibrate is better compared to all this. The reason why fenofibrate is better because it doesn't interfere with statin metabolism. It doesn't interfere with statin metabolism. And they have done studies where the risk of myopathy is least with that. See, the myopathy risk will be there, but compared to other fibrates, the risk is least and it will not interfere with the metabolism of statins. You know that if you interfere with the metabolism of statins, the statin levels are going to increase and myopathy risk increases. So that is about the drug fibrates. The next target, what we are going to discuss in dyslipidemia, will be a vitamin, and that is called niacin. So niacin belongs to the vitamin B3. Now what is the mechanism of action of niacin? To understand that, let me give you an idea. These are adipose tissue. So adipose tissues, they contain an enzyme called hormone sensitive lipase. HSL stands for hormone sensitive lipase. They will cleave this and release triglycerides. From triglycerides, you get free fatty acids. Now these free fatty acids are taken up by the liver. So they are taken up by free fatty acids are taken up by the liver and they are utilized to synthesize VLDL. So the free fatty acids that are released from the adipocytes are utilized to synthesize VLDL. You know, from VLDL we get IDL, LDL, all those things. So thinking this mechanism, what we did is we use niacin. The B3 is going to inhibit hormone sensitive lipase. So the mechanism of action is to inhibit the hormone sensitive lipase. So what happens when you inhibit that? There is decrease in free fatty acid. There is decrease in free fatty acid delivery to liver. So when you inhibit hormone sensitive lipase, there is decrease in free fatty acid delivery to liver and there is decrease in VLDL synthesis. So that is the major mechanism of action of niacin. Now such a beautiful drug, it has the advantage, it increases HDL. Remember, out of all the drug, maximum increase in HDL is done by niacin. Whatever drugs we discussed in dyslipidemia, the maximum increase in HDL is shown by niacin. Niacin also decreases apolipoprotein A. So these are the two advantages of niacin. And also it can decrease the VLDL, LDL, triglycerides, and also it can decrease the total cholesterol. But the major action, if you observe, is to increase LDL. That is the major action. Such a beautiful drug, niacin. But when it has so much of advantage, why it is not used commonly? The problem is adverse effect of niacin. What is the problem? The problem is niacin causes cutaneous vasodilation. So cutaneous vasodilation, patient will have flushing. Patient will have the feeling of flushing when you use niacin. Second important problem is pruritus. So it starts producing itching to the patient. The reason is prostaglandins, that is particularly PGD2, plays a role in causing pruritus. Now how to avoid this pruritus? You can give niacin sustained release. So slow release or sustained release niacin can be given, or you can give aspirin. Aspirin can block the action of prostaglandins and decrease the pruritus. The other problem what we see with is myopathy. So if you observe all the three drugs we started discussing, all of them can cause myopathy. You take the example of statin, fibrates, and niacin. Not only that, it is shown to increase uric acid. So don't give it in a patient with gout. And also it can increase new onset diabetes mellitus in the patient. So it can increase the new onset diabetes. And another important problem is dyspepsia. So please remember, even there's a very beautiful drug niacin, it's not so much popular. The reason is the flushing, pruritus, uric acid is increased, risk of diabetes is increased, patient will have dyspepsia, as well as the risk of myopathy is still there. In the exam, if they ask you, can we combine statins plus niacin? Why we should not combine? Because when we combine statin with niacin, what is the risk you're going to increase? Is obviously the risk of myopathy. So try to avoid this combination. The myopathy risk is going to be increased. Now, the question is, can we use niacin in a pregnant woman? Niacin is contraindicated in pregnant women. So if a pregnant woman has hyper or she has dyslipidemia, can we use niacin? No, because the niacin what we have used in animals, the dose what we use for dyslipidemia, that dose if I used in animals, it has shown some teratogenic effect in animals. So we don't want to take the risk and give to the pregnant women, that is humans. We don't want to take a risk. So animal studies have shown teratogenic effect, that is a dose used for dyslipidemia. What the vitamin B supplementation what we give pregnant women, that is a lower dose, no problem. But the dose what we use for dyslipidemia is higher, so that dose cannot be given. The reason is animal studies have shown teratogenic effect. So it is contraindicated in pregnant women. Very, very basic question. Now the next drug what we are going to discuss, they are a group of drugs called bile acid binding resins. So they are called as bile acid binding resins. Now what are the drugs in that? We have cholestyramine, then we have cholestyramine, and one more we have cholesevelam. So these are the drugs, and remember cholesevelam is also used in, it is also approved in diabetes type 2. So not all the only the cholesevelam is approved. You read the name, all of their names start with chole. Cholestyramine, cholestyramine, cholesevelam. How do they work? What is the mechanism of action? Let us understand here. Coming to the mechanism of action of bile acid binding resins, let me draw. This is the intestine and this is the liver. Yes. Now, cholesterol is required to synthesize the bile acids. And you know the role of bile acids from physiology. And the bile acid is secreted from the liver into the intestine. Now, the drugs resins what we give, when the patient takes resins, remember these resins are charged. So resins, because they are charged, they are not absorbed from intestine. So let me write, they are not absorbed from the intestine. That means they don't reach systemic circulation. Their action is only in the intestine. These resins will bind bile acid and both of them will go out in the stool. So resins will bind with the bile acid and they will remove the bile acid. Now what happens when the bile acid is removed? More and more cholesterol will be diverted towards bile acid synthesis. Now when the cholesterol decreases in the liver, what happens? The liver try to take up the cholesterol from the periphery, and that is the reason why it can decrease the LDL, it can decrease the VLDL, and it can decrease the total cholesterol. So the cholesterol is diverted for bile acid synthesis. More bile acid, they will go in the intestine, they are depleted out. So same thing. So cholesterol comes down in the liver and more cholesterol is taken from the periphery and given back to the liver. That is a mechanism. Now since they are not absorbed from the intestine, can we give it in pregnant children, lactating women? Yes, you can give it because they are not at all absorbed. So moving on to the uses, these drugs are safe in pregnant children, and lactation. Now, why they are safe? They are not at all absorbed and there is no systemic adverse effect. They don't cross placenta. That's the reason they are safe to be used. So, any patients having dyslipidemia, then we can use this and they are safer. What are the adverse effect? The adverse effect is bloating and patient may complain of constipation. Patient may complain of constipation and some bile acid binding resin they can mild increase in triglycerides. So they can increase triglycerides. So don't use this bile acid binding resin if a patient has hypertriglyceridemia. So what are the bile acid binding resin which can increase it? They are called cholesterol and cholestyramine. They are known to increase triglyceride a bit. Cholesterol, we don't have data, but remember these can increase the triglycerides. Moving on to the last target, they are called the inhibitor of intestinal cholesterol absorption. So the fifth drug inhibits intestinal cholesterol absorption. The name is called ezetimibe. So the inhibitor of intestinal cholesterol absorption, the name is called ezetimibe. What will happen here is, this is the intestine and this is the liver. Now when we use ezetimibe, this drug, the cholesterol absorption which has to happen is stopped. So cholesterol absorption doesn't occur. Now when you don't allow cholesterol absorption, what happens? The liver has to synthesize cholesterol, so it will increase cholesterol biosynthesis. So one thing what we did is good. We didn't allow cholesterol to be absorbed, but what is the bad thing happening? The liver started increasing more and more cholesterol synthesis to compensate for that. So the purpose is not served. So that's why what happens, to avoid this compensatory increase in cholesterol biosynthesis, along with ezetimibe, we always should add statins. So statins, by inhibiting HMG CoA reductase, they inhibit this cholesterol biosynthesis. Please keep this in mind. Ezetimibe should never be given alone. What happens if I give it alone? There is increased synthesis of cholesterol. So whenever I use ezetimibe, it should be always combined with statin. It is always combined with statin and given. So this is one of the important things you need to keep in your mind. Now, why are we giving then ezetimibe? Certain times what happens, I gave statin, patient started having myopathy. So I cannot give higher dose of statin. So what I do, I will add statin with ezetimibe when the statins doesn't work properly or statin patient cannot tolerate. That time ezetimibe can be given, added to the regimen. So until now we have discussed 5 class of drugs: HMG CoA reductase inhibitors, then the fibrates, then niacin, then we discussed bile acid binding resin and ezetimibe. So I will give a list of drugs. What drug cause maximum decrease in LDL? And that is done by statins. What drugs decrease maximum triglycerides? And that is done by fibrates. What drug increases maximum HDL? Yes, any guesses? It is nothing but the niacin. So very, very important points. The maximum effect is seen with this. So statins are the best drug which decreases LDL maximally. So once we are done with that, let us discuss certain newer drugs. Newer drugs in the management of dyslipidemia. Number 1, we have a group of drug called PCSK9 inhibitors. So we have PCSK9 inhibitors. What is the name of that? It is called alirocumab. And one more is called evolocumab. Now, as you see the name, they end with MAB, they are monoclonal antibodies. And you can get a clue from that, OC for over cholesterol. So the drugs are used for over cholesterol conditions. So OCumab, they are for hyperlipidemia condition. So where to use them? These are used for familial hyperlipidemia conditions, and also they are used in prophylaxis of atherosclerotic cardiovascular disease. So what is the role of PCSK9? Why should I inhibit this? Is a big basic question. Let me explain that. Now this is the liver. This is the liver. Now liver should have the receptor called LDL receptor. So these are LDL receptors. Yes. Suppose this cholesterol is very much high in the periphery. That is, LDL is high in the circulation. So that is taken up back to the liver with the help of LDL receptor. Now we have a protein in the liver that is called PCSK9. This will degrade the LDL receptor. PCSK9 will degrade LDL receptor. Now tell me, if you degrade LDL receptor, what is going to happen? The LDL is not going to be taken up by the liver. The LDL level is going to rise. So when you destroy LDL receptor, the LDL is not taken from the periphery. The LDL levels are going to rise. So what should I do? Stop the action of PCSK9. So if I inhibit PCSK9, there is no degradation of LDL receptor. So the LDL receptor remains intact, and they will take up the LDL from the periphery and decrease LDL. So that is a mechanism of action of PCSK9 inhibitors. The other newer drugs, apart from this PCSK9, the other drugs are a drug by the name lomitapide. Lomitapide, the mechanism is it inhibits microsomal triglyceride transport protein. So it inhibits microsomal triglyceride transport protein, and that is lomitapide. We have a drug called mipomersen. It is called mipomersen. It is an antisense oligonucleotide. It is called as antisense oligonucleotide. Now what do you mean by that? Now you all know that mRNA carries the message which proteins will be synthesized. For example, we have an mRNA to synthesize ApoB100. Now, how do I silence this mRNA so that ApoB100 is not expressed? So what we use is mipomersen. Mipomersen will attach to this and it will not allow the mRNA to express. If mRNA is not expressed, what happens? There is decrease in ApoB100. So that is the mechanism of action. So mipomersen. Now I just want to compare one more drug, fomimersen. Have you heard of that? It's an antiviral drug used in case of herpes. We'll discuss that later, and also it is used in cytomegalovirus, particularly fomimersen for resistant cases of cytomegalovirus. So compare that. When we come to fomimersen, you have to remember mipomersen. Then we have another drug, and that is called icosapent. Icosapent is known to inhibit synthesis and release of VLDL from liver. So it is shown to decrease the synthesis and release of VLDL from the liver. All these drugs, newer drugs, are approved for familial conditions, familial hyperlipidemia conditions. So number one, lomitapide. You remember MI for microsomal, T for triglyceride transport inhibitor. Mipomersen, anything ending with mersen, they are antisense oligonucleotide. They block the mRNA expression and they decrease ApoB100. Icosapent inhibits synthesis and release of VLDL from liver, and they are approved for familial hyperlipidemia condition. Recently, there is an acid that is approved that is called bempedoic acid. So bempedoic acid, it inhibits an enzyme called ATP citrate lyase. So you know that biochemistry, citrate, we get acetyl CoA. From acetyl CoA, the cholesterol biosynthesis starts. Now There it inhibits from citrate to acetyl-CoA synthesis. The bempedoic acid stop the enzyme called ATP citrate lyase. And very, very important drug because it's newly introduced to the market. Where to use it? Two important condition, atherosclerotic cardiovascular disease, as well as it is approved for familial hyperlipidemia conditions. Right. So this is about the drugs for dyslipidemia. I started the topic by telling what is the reason why we use the drugs. Remember particular statins. Statins particularly remember the adverse effect myopathy. Can we give it in pregnant? No. And don't combine with enzyme inhibitors. The risk of myopathy or abnormalities increases. Maximum decrease in LDL is done by statins. And diabetes with dyslipidemia, the drug of choice will be statins to decrease the LDL. High intensity statins, there are only two, atorvastatin and rosuvastatin, and they decrease the maximum LDL. That is more than 50%. Fibrates, they all end with fibrate. They stimulate PPR alpha and they increase lipoprotein lipase and they cause maximum decrease in triglycerides. Niacin is a B3, very good drug to increase HDL, but the problem is adverse effect. It can increase the risk of diabetes, increase uric acid, flushing, and also it can cause pruritus. But it is not at all used in pregnant women, it's contraindicated. Then we have bile acid bind resins, safest in pregnant children, lactating women, and they are not absorbed. Then next we have ezetimibe. Ezetimibe should never be used alone. It should be always combined with statin to avoid compensatory increase in cholesterol biosynthesis. Newer drug PCSK9 inhibitor, alirocumab, evolocumab, they will be asking you. The other drugs are lomitapide, mivomersen, then icosapent. Recently, we have come with a drug called bempedoic acid. So that is about drugs for dyslipidemia. Thank you all.